Hello, my name's Kate Steiner and I'm an interventional radiologist from the UK. I have a specialist interest in AV access interventions in particular. Early intervention in AVF maintenance is really important, and I think in order to offer optimum patient care, we all need to offer a responsive service rather than a reactive service for several reasons. One is it is much more difficult to salvage a fistula when the fistula has thrombosed. It's also a much more traumatic experience for the patient. It's a very different procedure, declotting a fistula, compared to a straightforward fistuloplasty. And by offering early intervention, we can treat the clinical symptoms of dialysis access fistula dysfunction early, which makes a huge difference to the patient's quality of dialysis, sometimes also their quality of life when you're going to a dialysis unit 3 times a week for intervention. So we've just completed a prospective observational study called the AV SONOPATH study. And that study was examining lesion type. We had some interesting findings on both the ultrasound and the histology. The majority of lesions had some degree of intimal hyperplasia on ultrasound, on histology. And in terms of the specificity, we were 100% specific. So there were no false positives on ultrasound. So we know that from our results, it seems that ultrasound is very accurate in measuring and also establishing the presence or absence of intimal hyperplasia. And I think as we move forward with AV access intervention, we have more options that we can offer the patients. And now we have this concept that not all lesions are the same. It's how we develop as a community an algorithm for treatment based on lesion type and other patient factors, the right treatment for the right patient at the right time with the right intervention. I don't think we're there yet, but we're kind of on the way there, which is quite exciting. I think the data that we have for the IN.PACT AV study shows that there is a benefit for DCBs in terms of reducing number of interventions and also the primary patency rate. We had the 3-year data demonstrating a sustained drug effect, which you would expect over time to lose some of that drug effect as the drug effect wears off, but those efficacy curves still remain separated out to 36 months. So I think that we do have that good evidence for the use of paclitaxel therapy in AV access, and it's now where we adopt it. I think some of the next steps are incorporating the appearances and the ultrasound with a study. So recurrent stenosis affects patients' lives in several ways. If it becomes a recurrent stenosis that then is symptomatic and significant, then we'll need another treatment. And if you're already going to the dialysis unit 3 times a week for treatment, to come back again and again for repeated angioplasties, which while we endeavour to make our patients very comfortable, are uncomfortable when we inflate the balloon. If we can prolong the time between repeat interventions, then that's better for patients. And having treated many, many patients over the years, they will comment on that. When did I see you last? So, well, it's only been 4 months this time. And if they go for a year, 6 months to a year, then for them, it really makes a difference.